I will now hand over to Valerie for her questions. Valerie, you're on.
Yeah, so, PCOS affects 1 in 10, as we discussed, and that's like over 5 million cases in the U.S., which is it's pretty hard to diagnose, though. And I'm just curious, what's the correlation if a patient wants to pursue, like, egg freezing or retrievals for IVF and fertility treatments if they are diagnosed with PCOS? What can be their expected outcomes for those treatments?
Yeah, thank you for bringing this up because we haven't talked about fertility at all. Let me go back, though, Valerie, and say that PCOS is really not hard to diagnose, and that's what I was trying to elaborate on at the beginning of this talk, is that it's really a diagnosis based on these 3 criteria. And if we take a good history from our patients, do the blood work and an ultrasound, it is not a hard diagnosis to be made, but one needs to be diligent and do the testing rather than just look at our patient or just review some of the symptoms and say, oh, maybe you fit into it without going into the details. So coming back to the fertility aspect, I spend a lot of time reassuring our patients that this condition is not going to result in them not being able to get pregnant. It is something that's always on their mind. When the young girls come to see me, it's on the minds of the parents who come with them. And there's a lot of misconception out there that the diagnosis of PCOS is going to result in tremendous difficulty with fertility. In fact, when we look at these ovaries, there are a lot of eggs in there. So from a fertility specialist's point of view, I am very pleased when I see these ultrasounds because my patients have excellent ovarian reserve or a high number of eggs, and all I have to do is help them release these eggs. So most of these patients don't even need IVF as a first-line treatment. If we give them medications, they're just tablets by mouth. There are 2 medications currently available in the market. One is called Clomid or Clomiphene, and the other is called Letrozole. And both of these will help them ovulate. Weight loss will help the periods become regular and sometimes help them ovulate. So a large proportion of our patients will get pregnant with easy first-line therapies for fertility. However, if somebody does come, like you're asking, for egg freezing because they don't have a partner yet, they're not ready to be pregnant, but they just want to freeze their eggs, then that is an option after we discuss all the pros and cons of egg freezing, like it would be for anybody, not just for PCOS. And then again, one has to be careful because since they have so many eggs in the ovaries, one has to stimulate them mildly. We do not want them to be at a risk of hyperstimulation. We don't want to use excessive hormones in this particular group. And most physicians who have the expertise in IVF will know to use milder protocols for women with PCOS. So again, I'm hopeful that the outcome should be good because in general we should be able to get more eggs for freezing if a woman with PCOS is interested in that option.
Thank you, doctor. That was a great explanation and could help anybody that is borderline or thinks maybe they might have it. I know personally I have had many follicles on my ultrasound, and so, at times I've always wondered if I had PCOS myself. But since there's no cure for PCOS at the moment, can you talk about a couple of treatment or management tools, maybe like a natural supplements, or, like I know there's some research being done currently, like with Crown Fertility, looking at how they can help manage PCOS with more of a natural approach?
Yeah, I think, again, this is a good question because given how young our population is, they don't always want to be on medications. And there's no one-size-fits-all for PCOS, so it depends on what the symptoms are. Not every patient with PCOS is going to have all the symptoms that we have been discussing, and it's very important to engage the patient and say, what is the symptom that bothers you the most, and what would you like us to focus on in terms of treatment? And so the reason one would want to make the periods more regular is if the patient's going to have 1 or 2 periods a year, there is an increase in the risk of cancer within the lining of the uterus as the patients get older. So that becomes an important medical treatment because now we are talking about a risk of cancer over a longer period of time. Natural treatments that can help improve the periods, one of the most successful is weight loss because as the weight comes down, Dr. Amaro reviewed how the action of insulin will improve, the male hormone levels drop, and so any supplements or any other interventions that'll help change weight and decrease weight can be useful. There are medications on the market that are insulin sensitizers but are not prescription medications, and a number of your listeners will know what I'm talking about. They fall in the Inositol category, like Inositol. And so these are supplements which are working along the same pathways that we have discussed here. And if they help with weight loss, and they usually will help in addition to other things that our patients are doing. I don't think we can give any of these supplements credit by themselves. Typically, our patients are putting in the effort to count their calories, engage in exercise, etc. But that'll help with improvement in the menstrual regularity. The high male hormone levels will come down as a patient gets older. So when we say there's no cure, as these ovaries shrink, because that's where the male hormones are coming from, and as a woman gets closer to menopause, symptoms of PCOS do get better and the male hormones will decrease. So it's, again, if there are symptoms related to the high male hormone, one could manage it by just managing the acne or the hair growth by mechanical ways of removing it. If the patient does not want to take any hormonal treatment to drop the male hormone levels, and one could certainly recommend just topical stuff for management as well. So I do think there is a role for supplements or natural ways of managing PCOS, but it depends on what the symptoms are, how severe they are, and we do want to weigh the pros and cons of how effective these treatments can be.
Great. So if somebody is on birth control for an extended period of time, let's say over 10 or so years, is there any research or studies that can detect if that will help with the management itself or if it just masks the symptoms?
Yeah, this is a good question. We have a lot of patients who believe that, right now, as I described, birth control pills are first-line treatment for PCOS, and there is some frustration that this is masking the syndrome. So the way I explain it to my patients is there are a couple of things that I want to make sure that we are helping treat. And as I just described, one of them is I do want to decrease the risk of, or any risk of cancer if the periods are irregular. If the periods are coming 8, 9, 10 times a year, that's not a concern, and we have patients keep a menstrual calendar. But if you get 1 period or 2 periods a year, that is of concern, and I think the physician then does need to treat them. And the birth control pill becomes a nice way to treat it because a birth control pill has 2 hormones which are combined, so the patient doesn't have to take 2 separate pills, and that is the reason it's chosen. It's not chosen because it's a contraceptive. It's chosen because it has these 2 hormones which help us protect the lining of the uterus. That's the progesterone hormone, and then the estrogen hormone helps decrease the male hormone levels. So now we have one medication that controls 2 symptoms. So Again, it's not a matter of just masking it, but we are actually trying to prevent complications of PCOS when your physician is prescribing some of these medications. But they will always talk to you about lifestyle management, which we do also believe is first-line treatment for PCOS. And very often I have my patients stop the medication for a few months to see. Now that you're older, maybe your periods are back. Now that you're older, maybe the male hormones have dropped, and we don't need to be on these therapies sort of lifelong. These are there for short periods of time, and one can always reassess. So I think it's a good idea to come off medications intermittently and see what the PCOS symptoms look like and what the need is. Of course, patients come off these medications when they're interested in having a family and get pregnant as well. So there will be interruptions in these treatments, and it's always a good idea to reassess the symptoms.
Great. Do you think you could share what I often hear with a lot of the patient advocacy work and patients that come to me is that, they're confusing the difference between endometriosis and ovarian cysts and PCOS. Do you have any good differentiators or ways to explain these health conditions so people don't confuse these problems?
Yeah. No, again, these are such good questions that are coming up. So endometriosis is a condition where typically what we believe is when a woman gets a period each month, some of the blood, instead of flowing out of the vagina, may go backwards and flow out into the body through the fallopian tubes. And then there can be an adverse reaction to this blood that's in the belly. In most women, it doesn't stay around and it gets absorbed over time. But in a small group of women can have a more severe reaction to it, and it can stay around. There can be inflammation, and we call that endometriosis. Endometriosis is associated with painful periods, painful sexual activity, and if it's severe, even pain when a woman urinates or has a bowel movement. So the symptoms are very different to that with PCOS. But interestingly, the treatment is very similar. Birth control pills do help and are first-line treatment for endometriosis as well. Now, an ovarian cyst that a woman typically may double up in pain or go to an emergency room or have an ultrasound and get diagnosed with is one follicle in the ovary that becomes large over time, and then because it has stretched out and become large, causes pain. So a cyst in the ovary typically will be 2, 3, 4, 5 centimeters or even bigger. Sometimes it can rupture, and that causes the pain. So that's an ovarian cyst, typically one large growing or one or two large growing cysts in one or more ovaries. Again, the treatment for that is a birth control pill because we suppress those ovaries so they don't form cysts. And then again, to recap, with PCOS, it's just little follicles, and because it's a genetic condition, we believe that women are just born with a higher number, and then over time, this number will decrease as they get to menopause. Interestingly, there's some data that women with PCOS will go through menopause later. So the average American woman goes through menopause around the age of, say, 51. And there's data that now says that because women with PCOS have a high follicle count, they may go through menopause maybe 2 or 3 years later than the average woman because these ovaries are shrinking on a different scale, timeline, compared to somebody who doesn't have PCOS. So again, PCOS ovaries should not cause any pain because these follicles are small. They're not large like an ovarian cyst. And they're usually picked up on an ultrasound. They're not picked up because somebody is complaining of pain in the ovaries.
Got it. Great. Well, just real quick, I think we have time for maybe one more question, right? How can somebody start? If they think they're suffering from PCOS, what's a good place for a patient to begin this process of getting diagnosed?
They need to reach out, as I said, to their physicians, and given that we now have this international consensus that the diagnosis is based on these three criteria, it should be possible that for the young girl, the pediatrician, as you get older, the internist or the family physician, the OBGYN, should be able to make this diagnosis. Unfortunately, there aren't as many specialized PCOS centers all around the world or even in the U.S. as we would like, but the diagnosis has been simplified, and in general, I would think that a large proportion of our patients should be able to get an accurate diagnosis using these criteria, and not everybody has to reach out and seek out specialized centers.
Great, thank you.
Thank you, Valerie. We'll just jump into some questions from the audience now. So Dr. Allison and Dr. Amaro, we have been receiving a lot of questions on the type of diet that you need to follow for PCOS. And they've been asking about whether people should follow gluten-free diet, or should they be following a dairy-free diet, whether it will help if it's a ketogenic diet. So what diet should women with PCOS follow?
Well, this is Dr. Allison. Unfortunately, there are not that many randomized controlled trials of women with PCOS to really answer these questions well. But we have studies of folks with diabetes, and that may be the most similar comparison that we can make. And in general, we still believe that whatever diet somebody is able to follow on a longer-term basis is probably the most effective for that person. And I think as we get further with precision medicine, we will come to understand if somebody, loses weight better on something like a ketogenic diet versus just a low-fat diet. We aren't quite there yet, but when I see my own patients, if somebody is more sensitive, to eating carbohydrates and they do find it more difficult to lose weight, then I would work with them to say, okay, how can we, because maybe their cravings are stronger and maybe that leads to some binge episodes, then we would say, okay, how can we either eat those in moderation, or if they wanted to do something as extreme as ketogenic, I generally try to stay away from cutting out whole food groups or whole food types out of diet. It's just too hard to maintain, and then it leads to kind of black and white thinking, and then when you get off of it, it's hard to keep up with weight management efforts. You feel like you failed, or your body is giving you all these cravings. But one size does not fit all. But I just don't think there's any definitive evidence to say don't eat dairy or don't eat gluten. And in fact, most of the time we do try to get people to eat in moderation so that they can follow a program long term.
This is Anastasia Amaro. I absolutely agree with Kelly. There is no one diet that fits all. Overall, people with insulin resistance, there are some signals from the studies that maybe more people will respond better to low glycemic index food. It's not a specific diet. It's a process of selecting more appropriate carbohydrates. So usually those are complex carbohydrates with lots of fiber. They are so-called low glycemic index, so they induce less of an insulin spike. Because women with PCOS already have plenty of insulin on board, so any excessive insulin production can kind of contribute to this vicious cycle of being hungry, eating more, gaining weight, producing more insulin. And there is no evidence currently in favor of gluten-free diet. In fact, sometimes I'm afraid we're seeing that people who decide to go on gluten-free diet tend to select higher glycemic index carbohydrates, so that may not be that good. Gluten-free diets are definitely indicated for people who have gluten insensitivity or true celiac disease. They may or may not have PCOS, but that's a separate condition.
Thank you, doctors. Dr. Dokers, I will just, we've covered most of the questions. There's still a couple remaining with regard to fertility. I just heard you say that if you have PCOS, your fertility is not affected much. So we have a question says, how can I manage my symptoms and still get pregnant? And she says, I was told the pill is the best way to control PCOS, but I want to be pregnant.
Right. So usually when our patients are ready to be pregnant, we then have them stop the birth control pill that has been prescribed as their first-line therapy. And if they don't get their periods, haven't come back in a good pattern, like they are not getting a period within 6 to 8 weeks of having stopped the pill, then it means that we are going to need to help them ovulate. And as I mentioned, there are 2 medications that are available to help with that. So usually what we would do is before stopping the birth control pills, we counsel patients about weight management, make sure that their sugars and their glucose numbers are good, and have them all ready for pregnancy. And then we would stop the birth control pill and not be without any treatment for months and months on end, but actually have a plan that if the periods are not back and you're not ovulating on your own, then we are going to help with ovulation. On the other hand, a proportion of patients do have regular periods once they stop the pill, and then we would teach them how to use the ovulation kits to detect ovulation and to time intercourse appropriately to help them get pregnant.
Thank you, Dr. Dokers. We're already over time, but I just have one last question. The Penn, the PCOS Center of Penn is doing a lot of research on PCOS, so it would be great if you could just touch upon some of the other interesting research that's happening at the center.
Yeah, so we have the PCOS Center at Penn has it's a multidisciplinary approach, and that's why today we have both Dr. Amaro as well as Allison on the line, because we believe that offering a sort of multidisciplinary approach to this condition is extremely important, and that has led us to do studies in the field of understanding the risk of depression, anxiety, eating disorders, and then body image distress. So all of these 4 aspects. Dr. Allison has been a collaborator with us, and these are some of our ongoing studies to better understand the link between PCOS and these conditions. We have also engaged in conditions research trying to understand if losing weight prior to getting pregnant is helpful, or being on a birth control pill prior to getting pregnant is helpful. And you heard some of those answers as to about a 5 to 7% weight loss will be important.